So, welcome everyone. Today, first I would like to thank Dbmci and Dr. Ramya for giving her valuable time to make this integrated video. And I think this integrated video will be very helpful for the students in actually understanding obstetrics. So, let's start.
Thank you so much, Ajay sir. I think they'll have a feast
I'm Dr. Ajay
understanding
Yadav.
the
I'm
obstetric anesthesia.
So, I'll start with cesarean section. So regarding choice of anesthesia, beyond any second thought, the choice of anesthesia is spinal, and spinal. Why? Because of the multiple reasons. The most important being is that obstetric patients are such high risk of aspiration that the risk of aspiration is 8 times more in obstetric patient as compared to normal patient. So that is one of the most important reasons for which we avoid anesthesia as far as possible. So we'll not go in much physiology that why they are more vulnerable for aspiration. Or
I would add one point.
Yeah, she can add that what are the most important reasons why they are vulnerable for aspiration.
So as sir has told, that's 100% correct that obstetric patients are more vulnerable for aspiration because most of the time when we take the patient for cesarean section, it is not a planned cesarean section. There are very few cesarean sections which we go for an elective cesarean section. Most of the time it is like where it's a failed induction or a fetal distress. So where the process of labor has gone, and during that process of labor, women would have ate just 10 minutes back or 1 hour back, and suddenly we are taking her for emergency cesarean section. So as most of our patients are emergency, so that's the reason why there is high chance of aspiration.
So I'll just add one more point. Actually, in pregnant patients, even if they are not fasting, even if they are fasting, I mean full 8 hours fasting, we still consider them full stomach. The reason being is because the most important protective mechanism against aspiration is the tone of lower esophageal sphincter. That's the only thing which prevent against aspiration. And the tone of LES is completely lost in cesarean section of pregnant patients for mainly two reasons. One, progesterone relaxes LES, and second, the normal gastroesophageal angle is mandatory to maintain the tone of LES. And this gravid uterus compresses the stomach and this angle is distorted. And once the angle is distorted, so LES become incompetent. So even if the patient is fasting, there is enough acid which is present in stomach which can cause severe acid aspiration pneumonitis. So pregnant patients, even if they are fasting, we consider them as full stomachs. They are very vulnerable for aspiration. So therefore, again, I like to say anesthesia of choice is spinal, and only spinal as much as possible. Now, as far as level of block is concerned, level of block required is up to T4. Why? Because although their fenestral incision is at around T11. Am I right, Dr. Ramya?
Yes, sir.
But during cesarean section, you people are going to handle
bowels
and bowels and peritoneum, the supply of which is up to T4. So level of block required is up to T4, and that's a very important thing for any surgery. We have to understand there's not only the skin incision, which all organs will be involved. Their nerve supply should also be blocked. So level of block should be up to T4. Then during spinal, two extra peculiar complications I like to say in obstetric patients, which are different from normal spinal. One, these patients are at very, very high risk of hypotension in immediate post-spinal period. That is because of supine hypotension syndrome. That I'm just going to discuss in next slide. Supine hypotension syndrome. So they're very vulnerable for hypotension, and there has been any case of cardiac arrest reported as soon as you give spinal. So supine hypotension syndrome pursues. So Dr. Ramya can add the physiology or important aspects of the supine hypotension syndrome.
As the gravid uterus, so the supine hypotension syndrome is a very important as per the MCQ purpose also, guys. So as the gravid uterus compresses the aorta vena cava, so whenever the patient lies down supine, because of the pressure on the vena cava, there is no venous return. So because of that, the patient will go into hypertension.
So that's another one very important thing. Yeah. And plus, we know that spinal also causes hypotension because of the sympathetic block leading to venodilatation. Already venous return is decreased, and this uterus compresses IVC, so it can completely decrease the venous return, which even can cause cardiac arrest, and we have seen this cardiac arrest. Second is that these
Sir, I
patients
have a
are,
doubt here. I have a
yeah,
doubt. Actually, I am learning a lot through this session. So, I have also seen one case, where as soon as the patient was given spinal, suddenly the patient has gone into cardiac arrest. And the patient was very short statured. Is there anything related to the short stature and going into cardiac arrest and hypertension,
yeah,
sir?
just coming to the next point that I am about to write. And in fact, it is a very important thing. So better I'll change the color of the pen also. High spinal. Pregnant patients are so vulnerable for high spinal, and the reason being is that that there is a venous plexus in epidural called as plexus of Batson, and the veins of this plexus of Batson, they directly drain into inferior vena cava. So whenever there is compression on inferior vena cava, these veins get engorged, and due to engorgement of these veins, these veins become so engorged that they push the dura medially, and when they push the dura medially, subarachnoid space decreases. And when subarachnoid space decreases, and if you inject the same amount of drug in that space, the drug will spread higher. So pregnant patients are so vulnerable for high spinal that in normal circumstances, we reduces the dose of local anesthetics by 30 to 40%. And in spite of that, we see maximum high spinal in pregnant patients. In my lifetime, I have seen 3 high spinal where I required intubation, means high enough to block even your diaphragm up to cervical level. Patient immediately goes in apnea. And
Yes,
all
sir.
those 3 patients were only cesarean patients, so vulnerable for high spinal. So that is the reason. And one of the very important criteria to decide the dose of local anesthetic is height. Because if it's a short stature patient and if you give the same volume, it will spread higher. Otherwise, also pregnant patients very vulnerable for high spinal. So that will become high spinal to block phrenic nerve, or even if it goes in cranium, that can cause total spinal. So total spinal,
Okay.
high spinal, along with the supine hypotension syndrome, and that will also lead to complete blockage of sympathetic supply of the heart, which you know is from T1 to T4. So that sympathetic supply of the heart get blocked. There is severe hypotension because all lumbar sympathetic chain is blocked, and your diaphragm get blocked. Even if it is cranium, there occur total spinal, so that can cause cardiac arrest. I think that would have been the reason in that patient.
Thank you so much, sir. I think it's really so much. I am also learning through this session. It's been a long time to,
Yeah,
learn
that
something.
that yeah, that is an advantage of actually integrated session.
So
Then
definitely, I am
third,
also learning, sir.
so then third important complication, in addition to the normal, what I'm telling, I'm not going the complication of the spinal, that these patients are more vulnerable for post-spinal headache. And the
Yes.
reason, as I already told you, that because of the decreased subarachnoid pressure, CSF pressure is increased. And when you puncture the dura with higher pressure, there will be more seepage of CSF. So post-spinal headache will be more. So
I would like
these
to
three,
add a few points
yeah, yeah.
about the post-spinal headache. So post-spinal headaches are more with epidural compared to spinal, sir?
No, no. Actually, until unless you are not puncturing the dura, then
Okay.
ideally post-spinal headache should not happen with epidural, because in epidural we are not puncturing the dura.
Right,
However, there is
right.
always a possibility of accidental dural puncture. So if there
Okay.
occur accidental dural puncture with epidural needle, then you know the incidence of post-spinal headache with epidural needle is 75%. So if that is punctured, 75% patient will have post-spinal headache. But overall, the incidence of accidental dural puncture in epidural should be less than 1%. So normally, the incidence of post-spinal headache with epidural should be less than 1%.
Right.
In spinal, we are using 25 gauge or 26 gauge needle. The incidence of post-spinal headache with 25 gauge needle is 2 to 3%. So in total, that is, I'm talking of the normal population. In pregnant population with the same needle, the incidence from 2 to 3% becomes 5 to 6%.
We do see post-spinal headache patients actually.
Yeah. So of course that way, yeah, yeah. So that is actually, I'll say that way spinal, definitely post-spinal headache will be more with spinal.
So epidural is more, it is better in
In terms
not
of if
having
you,
the side effect of post-spinal headache.
yes, that way you can say. But epidural
And
has it has many limitations. Like
right.
cesarean, I'll come to that point when
Yes.
we'll discuss.
So post-spinal headache, we give it decreases on the rest. And one of the, usually we give analgesics and we ask them to take caffeine.
Patient has to lie supine as much as possible.
Yes, so it decreases as they take the rest and next time.
So regarding post-spinal headache, your first line of management is patient should lie supine as much as possible. Adequate hydration so that CSF production always exceed the CSF loss. Then good analgesics, and fourthly caffeine. Caffeine is very beneficial. So at least 2 to 3 times patient should take. If not responding by these measures, then we go for second line that includes your triptans, sumatriptan, zolmitriptan, which are available. Even we are giving nasopalatine blocks. I'm not going those details. Otherwise, it itself is a very big topic. And in last cases, if not resort, then we go for autologous epidural blood patch. But that's the last bit. So coming back, so already we have discussed prevention of supine hypotension syndrome. That's very important thing. And then vasopressor of choice. Actually, why I included this, because this question actually has been asked 2 times in AIMS. Vasopressor of choice in pregnancy, 2 times this question has been asked. Once in NEET and once in AIMS. I think 2 years back only. At that time, question was ephedrine. But very recently, studies have found that phenylephrine is better than ephedrine. So today, if the same question comes, your answer will change. Phenylephrine. Why? What is the reason that why we select phenylephrine as a vasopressor in pregnancy and ephedrine as a vasopressor in spinal hypotension? Because important criteria for selecting a vasopressor in pregnancy is that how much vasoconstriction it is presenting, doing in uteroplacental circulation. Because if you cause excessive vasoconstriction in uteroplacental circulation, fetal circulation will be compromised. So ephedrine has found to cause minimum vasoconstriction in uteroplacental circulation. That is why phenylephrine is phenylephrine.
So one more point I would like to add here. So for the prevention of supine hypotension syndrome, as the complete supine position is more prone for causing this, so during the LSCS, we just make a little left lateral tilt of the
there are 3 ways to prevent supine. There are 3 things: left lateral tilt, or uterine displacement manual, and third thing is wedge. Under right hip. Under right hip. Now, among these, the preferred is wedge. Why? Because if somebody will manual do uterine replacement, who will do surgery? So that's practically not possible. Similarly, this with the lateral tilt, you also would have realized that sometimes it becomes very difficult for the surgeon to operate if you go for significant left lateral tilt, because you are standing on the right side. So it becomes difficult. So therefore, considering both things, the best is you have to just put a wedge under right hip. So that's the best policy. Fine. Now coming to GA. GA, already I told you that all patients of pregnancy should be considered full stomach even if they're fasting for 7 months. So they are always, even I'm telling full pregnancy, even if they've not taken food, then also we'll consider them as full stomach, and we will manage as rapid sequence induction. So again, I'll not go in rapid sequence induction because that's exclusively an anesthesia part. It will delay our discussion a lot. But all pregnant patients should be managed like rapid sequence induction. As far as anesthesia of choice is concerned, during general anesthesia I'm talking of, now induction can be done either with propofol, and until 3 years back, we were not using propofol because we didn't have enough evidence to prove safety of propofol in newborns. But there are now numerous studies, and propofol can be safely used. So there is no second thought about that. There's this second option is ketamine. And ketamine generally we prefer for full stomach patient because it preserves reflexes. However, there is a concern of using ketamine in obstetric patients specifically because it increases the uterine tone. Although at clinically used doses it does not increases, but theoretically it can increase. Therefore, generally many people, they try to avoid ketamine. So nowadays for induction we are using propofol. Now maintenance is an issue. For maintenance, the problem is that all our inhalational agents which we are using, they are uterine relaxants. But however, studies have proven that if you use in concentration less than half MAC, then it does not cause significant uterine relaxation. And that was a common trend that we are using our inhalation agent, but in concentration less than half MAC. But there is a recent evidence. They say that even if you use the normal MAC, 1 MAC, they does not cause a significant uterine relaxation. So this is again a very, very important recent advancement, very recent in fact, not even published in your standard textbooks also, that now we can use 1 minimum alveolar concentration of inhalation. Until recently, all books you will say we used to use half concentration, but now it is recommended that we can use even 1 MAC concentration. Then coming to painless labor. Painless labor, the gold standard is lumbar epidural. And you know, and Dr. Ramya must be knowing that nowadays when you say quality standards of a hospital, lumbar epidural, if not given, you lose a very important point of quality standard. So any obstetric center, if it is not giving lumbar epidural, it cannot be considered as a quality obstetric standard. That is why all, even our local guidelines also says that, forget about international. And so lumbar epidural is best. Now the level of block normally we required is up to T10.
So as the uterine nerve supply is T10, T11,
and Dr. Ramya can
T12,
focus on nerve supply of the uterus.
So nerve supply of the uterus starts from the T10, T11, T12 and L1. So that is why here for the painless labor, we are giving the blockade till T10 because we just want to stop the nerve supply. We want to just stop the nerve supply to the uterus. Now, many students ask me one question, Ki, when we are giving the painless epidural for the painless labor, will that decrease the contractions of the uterus? So the contractions of the uterus is in the biometrium is mainly hormonal.
Yes. So you are replying.
Sir, am I audible, sir?
Yeah, audible.
Yeah. So as the uterus is mainly through the contractions are mainly hormonal. So estriol increases the gap junctions, that is the connexin 40, followed by the oxytocin and prostaglandins help in the uterine contraction. So even though there is a blockade, nerve supply blockade will decrease the sensations or the pain sensations will be lost, but the contractions will be persisting. So although we are giving the epidural, so we are not going to prolong the first stage of labor. So the uterine contractions will continue, but there will be no perception of the pain. The second question which I tend to listen from the patients is regarding if you give epidural, what about the perineum? So perineum, so in the second stage of labor, when the patient is trying to bear down, when the patient is trying to push the baby, that time bearing down efforts are very important in the second stage of labor. So in second stage of labor, when we give epidural, usually she doesn't get that sensation to bear down. So when the woman lacks to have the sensation to bear down, and when the woman is not bearing down, because of that, second stage of labor can be prolonged when we give the epidural, right? So this is one thing, that second stage of labor can be prolonged in the epidural. That is why for the second stage, whatever our guidelines say or the timeline we have for second stage, when you give epidural analgesia, for all those we have to add plus 1 hour. So if we, on an average for a primigravida, if usually we wait for 1 hour for the baby to get expelled, here we can wait 2 hours for the baby to get expelled, because the bearing down efforts are lost. The mother doesn't have the sensations, she's not perceiving the pain, so she doesn't push. And one more thing is that do you require to give anesthesia before doing episiotomy if you have given epidural? Yes. So this is one question they usually ask, sir. See, most students think that anyway you have given epidural, why do you want to give local anesthesia while you are performing episiotomy? Would you like to enlighten about that, sir?
Yeah. Actually, very rightly, this is a very proven fact that the labor is prolonged by 1 hour. This is a proven fact. There is no doubt about that. However, there is no increase in the incidence of cesarean section. And in fact, there is a study, a very big concurrent study showing 10,000 patients, that the incidence of instrumentation is reduced by 20%. Generally, people think that patient is not able to bear down, so instrumentation increases, forceps delivery increases. But there is a proven study, 10,000 patients, which says that the incidence of instrumentation was 20% less in the patient who are given painless epidural. The thing is, as Dr. Ramya said, the problem is the patient is not feeling pain, so she is not putting effort in pushing. Otherwise, motor is not blocked. Muscles are working because we are only using, that's what I'm coming to drug. We are using ropivacaine or bupivacaine only in concentrations which produces only sensory block. So there is no motor block. So patient can, but she become relaxed. That's a problem. So that prolongs the labor. Second thing, yes, as far as episiotomy incision adding local anesthetic is actually not needed. Why? Because you are giving up to T10. So anything below that will be blocked. So there is a sacral block also. That's why you need not give pudendal block or any block, because sacral nerves are also blocked. So there is actually no need. So you can easily do episiotomy, because many times, but just by changing the concentration of the drug, we are getting cesarean section under the same epidural.
Yes.
So there is actually no need. Then if by chance you are not able to give epidural fails, or patient, there is a contraindication for epidural, there are many contraindications, we will not go in that. So in that case, we have an alternative, that is Entonox. And Entonox, is 50% oxygen and 50% nitrous oxide, and that is inhaled by the patient. It's not as effective as lumbar epidural, but as an alternative you can use. Now, IV opioids. Dr. Ramya, pethidine cocktail, pethidine Finargan cocktail used to be very popular. IM pethidine Finargan. Yes. Although nowadays nobody is using. However, regarding IV opioids, this remifentanil is a very beautiful drug, and we have started using remifentanil infusion, and I have used in many patients also for painless labor if they are not happy with epidural, or epidural fails, or there is a contraindication, as an alternative. Remifentanil half-life is just 8 to 10 minutes. So it gets metabolized in the maternal plasma only, so it doesn't reach its fetus. Even if little amount reaches the fetus, that is also easily handled by the fetal plasma. So remifentanil as an infusion is emerging as an not I'll say alternative, but as a second option if you are not able to give epidural. Now coming to specific situations, PIH. Regarding PIH, I'll tell you, basically, for years, decades and decades, we used to say PIH anesthesia of choice is epidural. But actually, honestly speaking, for the last 20 years, I have always given spinal for PIH patients. And now it has come officially in all our standard textbooks after 20 years. Because the problem is epidural onset of action is 50 minutes. 10 to 50 minutes minimum onset of action. Secondly, epidural patchy block is very common. It's not, and its motor block is not good. So epidural is not a good choice for cesarean. So therefore, epidural we restrict only for painless labor. So theoretically, I don't know why people were saying epidural, since books were saying epidural. So I was saying epidural, but actually me and all my friends and no anesthetist was actually using epidural for PIH.
Actually, there's a question also, sir. There was a previous year question.
If it is coming as an emergency, although with PIH. So PIH, the problem is, the only concern is these patients are uncontrolled hypertensive. So spinal, they go in sudden hypotension. So you be ready to prepare sudden hypotension, so you can safely give. And now it is in all books also. So nowadays I can write with a green pen also that anesthesia of choice for PIH is spine. Forget about whatever the book says or whatever we were saying before.
This is an update, no sir, because there is a one question key, what is the anesthesia of choice of PIH? I think I was also going with the epidural. Update. So spinal is the anesthesia of choice, right?
No,
so
I think it used to be. If you would have asked me, you would ask me 2 years before, I would also say epidural. I was also teaching epidural, but not happily teaching from inside, because I know this is not truth. But only thing, we have to go by books. And all standard books are not saying, but all our latest editions and all anesthesia up to date, they are mentioning article that now spinal is recommended and should be given.
Actually, in our practice also we give spinal only, sir. We don't
spinal
give
only. I have never given epidural for PIH. And elective surgery, even if you don't want, surgeon can wait. See, fetal output or fetal outcome depends on your skin incision to fetal extraction time. So epidural, you cannot wait for 15 minutes to anesthesia to set on, and then you start surgery.
To be frank, epidural first cesarean section is only used where she was like in epidural analgesia, and then we are shifting her for cesarean. So suddenly apart from that, I have not seen epidural being used as a anesthesia of choice for any situations.
And I have never used also in my 20 years practice. And no anesthetist have used actually. Yeah, it's spinal. But anyway, now they have documented, so you can students with your you
Yes,
can
sir.
say with your 36 board chest, you can write a spine without anything. And if they don't give you marks, you can ask board to contact you. No problem. Now, cardiac diseases mainly you encounter is mitral stenosis. That is most common RHD we encounter in practice. For mitral stenosis, now again, anesthesia of choice actually depends whether the disease is mild or severe. If mild to moderate, again we can safely give spinal. If disease is mild to moderate, but severe beyond any second thought, spinal anesthesia will be contraindicated. It will be G. But I have seen a question, and I think this question has come like patient with mitral stenosis coming, and they have not mentioned whether it is mild, moderate, or severe. If not mentioned, then consider it severe. Then opt for GA. But by chance, if you get a situation like patient mitral stenosis area is like this, and gradient qualifies her to be for mild, if they give clinical situation like that, then you can safely say spinal. But if they say severe, then GA, and if they don't mention anything, then consider it as severe and go for GA.
So what
Anything you
about
want to add?
intracardiac shunts and pulmonary hypertension? So any
Okay.
of these conditions which we are discussing, always vaginal delivery is best, but certain conditions, if we have to go for cesarean, these will be the anesthesia of the choice. So regarding intracardiac
So the
shunts,
thing is, yeah, I'll tell you. Yeah, shunt may be right to left shunt, or maybe left to right shunt. So right to left shunt, our aim is to increase the afterload, because right to left shunt, if you increase the afterload, shunt will reverse. And spinal causes hypotension, so it will decrease the afterload, so it will worsen the shunt. So right to left shunt beyond any second thought, anesthesia of choice without saying is anesthesia, because hypotension is not acceptable. While left to right shunt, hypotension is beneficial, because if you decrease the afterload, left to right shunt fraction will reduce. So left to right shunts we go for spinal, while right to left shunt we go for G. Fine. Anything else regarding cardiac? One more thing you said, pulmonary hypertension, na?
yes, so that's the same as right to left.
Yeah, fine. Coagulopathies, of course, no say that anesthesia of choice will be GA, but there are two conditions. Like first, I'll talk of INR. If INR is less than 1.4, we can safely give spinal. So if INR is less than 1.4, we can give spinal. More than 1.4, obviously GA. Similarly, another thing I like to add here is platelets.
Yes.
I think thrombocytopenia is next slide. I'll come to that. First, till INR less than 1.4, we can safely give spinal. Second, many of your patients you keep on low molecular weight heparin. There are many indications for which you keep patients on low molecular weight heparin, and they are on low molecular weight heparin. So if the dose is prophylactic, and all your patient doses are prophylactic.
Yes.
So if the patient is on prophylactic dose, we need 12 hours gap. So after 12 hours, you can safely give sentinel axle blocks. Sentinel axle blocks means
Spine.
spinal and epidural. When we say sentinel axle, means it involves both spinal and epidural. So if it is a prophylactic dose, you can safely give sentinel axle block after 12 hours. But if it is the patient is on therapeutic dose due to one or other reasons, then we have to delay this sentinel axle block for 24 hours. So majority of the patients are prophylactic, so we can safely give sentinel axle block after 12 hours. Regarding thrombocytopenia, majority of the pregnant patients will be having dilutional or pregnancy-induced thrombocytopenia. So very often, that we see patients with thrombocytopenia coming for cesarean.
Yes.
So
yes.
recommendation is, if the count is more than 80,000,
yes.
you can safely give spinal. Safely. Even if it is, even if it is
one
between
controversy, sir. Actually, some books give it as 50K and some
I'm
books
coming.
Yeah.
So if it is 80,000, by closing your eyes, you can give. 50 to 80,000 is also relative. Now you have to see that GA is risky, or if you feel GA is very risky, Like patient has difficult intubation, you will not be able to intubate. She can aspirate. She has taken food just before. So even they say if risk versus benefit weighs, then even for 50 to 80,000 you can give spinal, but that is relative. So should be avoided. But if deemed necessary, you can give. Less than 50 is an absolute contraindication. You cannot. In fact, less than 50 is an absolute contraindication for a surgery also. It's like if we are doing thrombocytopenia surgery, from one side you have to start platelets infusion and then you have to start surgery. So that's a controversy maybe because of 80 or 50. 80 fully safe, 50 to 80 relative contraindication. Avoid, but if deemed necessary, you can give. Less than 50 absolute contraindication.
So, yes, sir.
Yeah. Anything? You want to comment something?
So we had a patient who was an ITP, idiopathic thrombocytopenic purpura, with a platelet count of 8K. So obviously we couldn't give any of these anesthesia. So we had to go for vaginal delivery, taking a consent that whatever might be the outcome of the baby, we are going to conduct a vaginal delivery with platelets on one side.
Yeah. Then obviously patient in shock, particularly ABH or abruptio placenta patients, you are being rushing these patients. So yeah, so sometimes they bleed profusely. Ideally, it's not again absolutely mandatory. Before taking patient for anesthesia, systolic blood pressure should be more than 80 mm. But again, sometimes to save the life of the patient and thus save the life of the baby, we have to do surgery with unrecordable BP also. Like yesterday only we did one patient with abruptio and BP was hardly 40. So there was no option, no time for resuscitation. But ideally it should be, means from MCQ point of view, if they ask you what should be the BP before taking patient for anesthesia for shock, so systolic should be more than 80. And of course, anesthesia of choice is GA already. And during GA here, yes, whatever ketamine causes, we have to induce with ketamine because it causes sympathetic stimulation and increase the blood pressure. So even if there is increased risk of uterine tone increase with ketamine, still we go for ketamine.
Actually, it is more beneficial after the baby delivers because anyway, in these patients, the uterus goes for atony. So with the ketamine, it's a benefit because uterus will contract and it decreases the incidence of PPH.
Then just a few points about CPR in pregnancy. Addition to what we do in CPR, in pregnancy, very important is uterine displacement. And here we can do manual. Because left lateral tilt CPR is not possible, with wedge CPR is not possible. Here there is only way to prevent this hypotension syndrome is manual uterine displacement. So one person, and we had one, I think last month we had one cesarean, this pregnant patient, she had arrest. So duty of one person was just to hold uterus on. That was only her duty. Then they say normally soda bicarb we are not giving because soda bicarb causes carbon dioxide retention, which can cause paradoxical acidosis. But for pregnancy patients, because of the fetal acidosis, they say soda bicarb should be administered comparatively early. And patients are very vulnerable for aspiration. So normally in CPR, you can do continuous CPR with bag and mask. But here bag and mask ventilation is contraindicated because of high risk of aspiration. So patient should be early intubated as fast as possible. And normally we keep high FiO2 compared to normal because we have to maintain more oxygenation in cesarean patient compared to a normal patient. And emergency LSCS, if fetus is more than 25 weeks, at 25 weeks, I think Dr. Ramya, you can, our guideline says 25 weeks. If there's any change, you can comment on.
24 weeks. Now we are taking it as 24 weeks, sir, according to Indian Academy of Pediatrics. So any pregnancy beyond 24 weeks can be, 24 weeks is considered as a period of viability. So beyond 24 weeks, we call it as LSCS. Before 24 weeks, we call it as hysterotomy.
Because I actually...
But clinically,
that's why
in India, we still take 28 weeks, sir.
28 weeks, okay.
Practically.
Yeah. So, but actually from MCQ point of view, it will be then 24 weeks. Because that's what I'm saying, because now I also heard that new guidelines is for 24 weeks. One of my pediatric colleague was telling. But our books, latest editions, maybe in coming editions, it will be published. But still our books was saying 25 weeks. So that's why I wanted to confirm with you. And another thing is if LSCS can be performed within 4 minutes of maternal arrest. Now again, I think new guidelines are coming. They say 5 minutes, but still they have not yet published. They are still in journals and that, but still we go by 4 minutes. So from MCQ point of view, you can still go by 4 minutes, but now I think recently they are saying 5 minutes. So I think that should
Sir, one
majority of the things.
situation we'll discuss and then we'll end. So one more situation is regarding the uterine inversion. That is inside out turning of the uterus.
Yeah.
So whenever there is a uterine inversion, patient will go into both neurogenic shock, vagal shock.
Yeah.
So because of the vagal shock, again we have to go for whenever we want to pick up so ultimately what I've understood is whenever we want to pick up the blood pressure, so you have to prefer to go for general anesthesia, and whenever you're okay with the dropping of blood pressure, we go for the spinal anesthesia.
Correct,
so as in the uterine inversion, as there is an inside out turning of the uterus, so as the mother is going into vagal shock, we go for a general anesthesia, but we prefer a drug which will help in the uterine relaxation. So as the uterus is in a contracted state, I initially want the uterus to undergo relaxation. So what will be the drug of choice to relax the uterus?
All our inhalational agents, I told you, they are uterine relaxants. So we use their less concentration. Until recently, I told you that I discussed this thing also.
Propofol.
Yeah. No. Inhalational agent. Propofol has no effect on uterus. It is inhalational agent. That may be halothane, isoflurane, sevoflurane, whatever available to you. And all inhalational agent, they causes similar uterine relaxation. I know there is a question very popularly asked that which is the best uterine relaxant, and all MCQ books are giving halothane.
Yes, sir. Yes, sir.
But today, if this question come halothane, please don't mark halothane, because all inhalational agents nowadays, they causes equal uterine relaxation like halothane, and halothane nowadays is very rarely used. At least in advanced countries, it is obsolete. India still it is being used. So nowadays we can safely use isoflurane or sevoflurane, anyone. So all causes equal uterine relaxation. So whatever inhalational agent available at your center, and I think this was the question came recently 2 years back in AIMS, and the last choice was halothane, isoflurane, sevoflurane, all of the above. And still many question marked halothane, although they wanted to ask the same fact that all causes uterine relaxation. The answer was all of the above, not halothane. So there is no preference, all equally, exactly equal. Yeah. So
this is a new learning for me also, sir. So I think we can, it's a new learning, because I was also thinking the answer is halothane, sir, to be frank.
Yeah, because MCQ says halothane.
So I think that is going to definitely benefit so many students. So now we can mark that halothane, isoflurane and sevoflurane,
all inhalation agents of the current use.
Currently use
all. Current use halothane, isoflurane, sevoflurane, desflurane. 4 we are using. So all are equally effective. And there is no study to prove that one is better relaxing than other.
So I'll just summarize for the students, sir. So on the whole, so LSCS, the anesthesia of choice will be spinal. At every point, it is the spinal. The only certain situations where you prefer the general anesthesia, like when patient is in the shock, and in there also you have to see that the blood pressure should be more than, systolic blood pressure should be more than 80 mmHg. So shock, in the sense you can go for the ectopic pregnancy, ruptured ectopic, or when there is a bleeding placenta previa, or when there is an abruption. So in all these situations, when the patient is in shock, you go for a general anesthesia, and to increase the blood pressure, you can use the agents like ketamine. And so sir also has told us about the low molecular weight heparin, regarding the platelet count, regarding the coagulopathies, and regarding the cardiac. And one more correction, which or an important MCQ is, what is the anesthesia of choice in preeclampsia? It is the spinal anesthesia. It is no more epidural anesthesia. Sir, what about eclampsia, sir? Eclampsia?
Eclampsia GA. Patient already having convulsions, so obviously spinal is not possible. Eclampsia we have to give.
Yes. So eclampsia, the anesthesia of choice. This is also asked as a question. So eclampsia, the anesthesia of choice, will go for general anesthesia. So this is also important for us. And regarding the cardiac diseases, when it is mild MS or moderate MS, spinal will be the anesthesia of choice. Severe MS and right to left shunts, or pulmonary hypertensions, or Eisenmenger, there we can go for the general anesthesia. So this is a summary of, and I'm very thankful to you, sir, for doing an integration. I really learned so much from your session, sir. And I definitely understand why you are so much favorite for all the students, sir.
No, Ramyasree, no, you are no less.
No, sir, I am always your student.
I saw your comment. The students are appreciating you like anything, and I'll also thank you for giving your valuable time. I know you are too much occupied, but still somehow you could manage to find time. So thank you very much. And anytime you're
Thank
always accessible at our this medical Facebook, or there are many groups of students you are aware for which you can post your queries and they forward these queries to us, and we try to resolve them in a day, but sometimes it's busy, a day or two maximum. So you are always most welcome. And
You can
thank you
also put
again,
any
Ramya.
other queries in the comment box so that we can address them in the comment box below also.